No, but it makes sense what you're saying that rather than using that as a routine drug, once you reach the years, you just analyze the patient based on what the patient had left the small intestines and how the patient is doing or progress or not, and making sure that there's no significant dilations of the small intestine that you don't have to use tirzepatide. Now, this is my idea. I believe, like in patients, like for example, with the ultra short segment, that they already doesn't have ileocecal valve. They have lost the end of the small intestine where the endogenous teduglutide is made. And really that first year of life when you achieve maximal growth of the small intestine, which is the first year of life, which I say probably even the worst,
Right.
that you're going to require more parenteral nutrition. What any teduglutide that you're making, you are blunting.
Correct.
If patients that start with a wrong food and short bowel, they would benefit getting the drug before a year of age.
Yeah. Yeah.
These specific patients that they have lost significant amount of small intestine.
So I love the idea, and I think definitely should be tried. The issue would be, which I don't think it's an issue, but sometimes after you start using it and it's a shot, and you have to give a shot to your child every single day, and some of these kids are on a shot for a different reason, the families, they become impatient and they say, oh, it doesn't work. So my only fear is that that's awesome, and I don't think they would have any side effect from it, and if anything, they would help. But I would hope that people don't give up on the drug too early just because they've been on it for so long.
And then
Does
you
that
kind
make
of
sense?
a branch. Yeah, you burn that bridge.
Yeah, you burn that bridge, and still to this day, the gastroenterologists that in big meetings, intestinal failure meetings that use the medicine, we don't know what to do once the patient's off TPN. So if you get them off TPN onto teduglutide, which again, the studies have shown that, not everybody will come off TPN. The most patients you can drop the TPN by 20%, which doesn't seem like a lot, but if you have a child that's on 7 days of TPN and you can give them 5 days, and on Sundays they can go to church and have family day and not have to worry about TPN, quality of life, people will take it, right? And one day during the week where they can go to soccer and not worry about TPN, they will take it. But we all have patients that have come off teduglutide. Probably those are the patients that you've done diet, plus minus maybe surgery, and then you get to a point that they're only on 30% TPN, and that's it. Teduglutide does it. If I can talk in Spanish, le ponen la tapa al pomo, and you're done, right? But then what happens with that patient? And so then parents ask you, when can they come off this shot? Am I going to be on the shot forever? And the answer is, yeah, for now, that's the information we have. There's no recommendations on how you should wean it. There's a lot of anecdotal data, with people that have tried to come off and they have to go back on because it loses effect. It's a hormone. It only lasts in your body for minutes, right? So we have the experience in a few patients where the patient gets constipated and off-label. I don't work for teduglutide or have any stocks. We'll try weaning, either decreasing the dose or going to every other day. But other than that, most people don't know what to do with it. And everybody will say you have to stay on it for life. So that's very interesting. Something that's coming out nowadays is some of the newer GLP-2 products that are going to be twice a week. Some of them are going to mix GLP-2 and GLP-1. So there's the exciting thing, aside from when you and I started doing this, there's so many new drugs, hopefully, that will be coming down the line that gives hope for this condition.
Something that is difficult for me to track or to order because it takes forever when I order it is an amino acid that is produced by enterocytes released into the blood circulations, and it's been showed that it can give you an idea of how that intestine is progressing towards the rehabilitation, and that's the citrulline level. Are you following those levels on your patient?
We are. I think it's really useful. I always tell the residents, I use citrulline like a CRP, right? Like a CRP is a sign of inflammation. If you go to the ER and you order it and the CRP is really high, you may say, okay, maybe I won't send that patient home because they're sicker than another one. But you're not going to keep a patient just because of a CRP in the hospital, right? So it's the same. I think it's really interesting when you get the baseline citrulline and it's low, usually normal is 20 to 30. Say you have a 4, right? And you're doing diet and the patient's doing better, and then you get a citrulline, say 3 months later, and it's 6. Okay, well, that's good, And usually the studies have shown that a level of more than 13 tells you that patient should be able to come off TPN. Now, have I had patients that have a level of 15 and they're still on TPN? Absolutely. And sometimes you have to be careful. It's what we call it's affected by other things. So if they have a virus, the level may acutely go down, and then once you check it again, once they get better, it goes up again. So you trend it. I think it's more important to trend it, and as an extra piece of information, absolutely we use it.
And Jackson UM is doing the labs in campus, or is
Yeah.
something that you're sending out?
Yeah, we're doing them as part of the genetic program because it is a genetic test. Yeah.
That's awesome. Now, switching a little bit intense, it's still medical intestinal adaptations on side effect of long-term parenteral nutrition and liver disease. I mean, it's a lot to talk about this. I believe that liver disease associated to the chronic use of parenteral nutrition is not only the compositions that we're using in the TPM, is a lack of adapting the intestinal, that small intestine adapting or not using enough enteral nutrition to establish that enterohepatic circulation, or taking too long to push towards enteral nutrition. But I wanted to touch with you your feeling on the different kinds of intralipids that we use on parenteral nutrition nowadays. I'm a big advocate of towards the use of SMOF
Me too.
on my patients. I wanted to get your feeling in terms of when you're comparing SMOF with omega vein.
Yeah.
And I'm going to give you an example. So like the surgeons that I work with, they have a patient with significant cholestasis. They feel that omega vein using rather than SMOF is going to fix the problem. Mm-hmm. Or sometimes even in autologous, so you have a patient with liver disease, prolonged exposure to parenteral nutrition, they need omega vein. And omega vein is going to fix the liver disease. How do you manage this patient?
Yeah, so I agree with you for your love of SMOF. It is our gold standard. For those that don't know, SMOF is a combination of lipids. I always compare it to the Mediterranean diet, right? Because it does have the soybean, which is plant-based, but it has the MCT oil, olive oil, fish oil. So, it's kind of that combination. It's a mix.
And omega vein is all the fish oil.
Fish, right? So you and I are the generation of seeing a lot of babies die because of TPN. That's why back, 20 years ago, the only thing that saved some patients was transplant, and transplant was much more common because it was either transplant or death. That's actually one of the reasons I went into this. As a fellow, I watched 3 kids die my first year from liver failure, nothing to do with the gut, right? They died from liver disease, and you didn't have time to do rehabilitation. And that really is one of the things that got me interested in the field. So, fish oil was discovered back then in 2005, and it was produced as an anti-inflammatory, product to be used as an additive. So to add it to something. It was never meant to be used by itself. So the way that we recognize it in the field is more as a rescue therapy. So we do use it, but I would say with the use of SMOF, we're seeing less and less patients, get significant liver disease. So nowadays, usually when we have a patient that has liver disease on SMOF, there's other things going on. They may be getting, like you mentioned, they're not feeding. They may be getting a lot of infections that also worsens the liver. It's not just
or even translocation that you mentioned.
Or even translocation, absolutely, that affects the liver, right? Which I think nowadays is the most common reason patients get liver disease. So when, I was training under you, we called it parenteral nutrition-associated liver disease. Now we call it intestinal failure-associated liver disease. It's not just a TPN anymore. That being said, for babies that are on SMOF, for some reason, say they get an infection and their bilirubin goes up significantly and it doesn't come back down fast enough, because usually you put them on antibiotics, they'll come back down. Those patients, we will use omega vein, but it's for a period of time. And usually they'll recover pretty quickly within a couple of months, and we'll switch them back to SMOF. I think I may have 1 or 2 babies that I've switched them back to SMOF and their liver got worse and we had to go back to omega vein.
But that's a good concept.
Rare.
But that's a good concept what you're saying. So it's more like a rescue therapy.
Rescue therapy.
And you use it for a period of time and then to transition to a SMOF.
Correct.
And one of the idea, I believe, is just because even though it's more anti-inflammatory, the omega vein, because of the high ratios of omega-3, than SMOF that has a combinations of omega-6, omega-3. But the SMOF has more essential fatty acids for growth and developing, and that omega bean doesn't have.
Right.
So rescue, transient, and then you move on back again to
Back
rehab and SMOF.
Yeah, and one of the things that, we learned when I was a fellow, one of the projects I did with you actually was back then when we started using Omega-Vin, because it was restricted, we felt that baby needed a certain amount of calories. So what we would do is that we would increase the glucose component, right? The sugar, the dextrose. And so from that point of view, we were getting them fatty liver from how much sugar they were getting. So they were getting a liver disease for something else, right? Nowadays, people are so scared of giving such high sugar that when they're on Omega-Vin, sometimes people don't want to go up on the dextrose. So for that period of time, you may be giving less calories. And now you're facing malnutrition associated liver disease, right? So that's why it's so important to really have like a subspecialized dietitian that knows, okay, if we're going to use Omega-Vin, this is what we're going to do with the sugar, and that's safe, but it's not too much. Having a good balance and for a short period of time. And sometimes one of the things we do is, if we're worried about essential fatty acid deficiency, as you mentioned, is that we'll do combination, right? So once the bilirubin starts getting closer to 2, which is less than 2 would be what we would consider normal, sometimes we'll do, Monday, Wednesday, Friday SMOF, and then the other days we'll give Omega-Vin to be able to give them some, essential fatty acids that way, right? Because again, as I mentioned, is a shortcut to me should be normal. If they could have other conditions, right? But for the most part, these kids are just, their gut is abnormal, but their brain works fine. So you want to make sure you protect that brain, that they're going to school, that they're getting their good grades, right? There's no reason to think that these kids are not going to excel in other areas of their life, but you have to give them the proper nutrition.
So now we're going to switch gears towards the surgical aspect of intestinal rehab. Then in terms of intestinal lengthening, what are your indications to use the step procedure or Bianchi? When you are foreseeing that your patient is going to need some kind of lengthening?
Yeah.
How often you will follow imaging on those patients or symptoms to pull that trigger? And why do you pick one versus the other, the Bianchi versus the step?
Yeah, so I think you need to know the expertise of your center and your surgeons. I'm often blamed for having favoritism among our wonderful surgeons. As you know, we have, probably 6 surgeons that work with us. And for the most part, on the outpatient side, I work more closely with 2 of the surgeons. And not because I don't like the other 4. I love the other 4. It's just I feel experience is key. The more you do, the better you get at it, the more you perfect it.
You
right?
let me know after the talk.
I'll tell you after who they are, exactly. And they know who they are because I get blamed a lot. But I think it's always about knowing the journey of the child, right? Just like we were talking about teduglutide. Now that teduglutide is available, do we at 1 year of age, start teduglutide? No. Now that we had her since 2005 when the step procedure came out, which was a lot easier for surgeons than the Bianchi, a lot of the pediatric surgeons all over the nation started doing them because you could learn, you see one, do one, teach one, right? And if you do 1 a year, you're not going to get the techniques that make the step better, right? Or you're not going to get good at picking the right patient for the right surgery. I remember back then, if a patient had no feeds and they were dilated, we'd say, let's step them. If you step bad bowel that's not adapting on its own, it's not going to adapt with a step. And I think because of that, the step procedure, which again is more commonly used because it tends to be easier, so people have more experience, it gave it a bad name. And there's, in the world of intestinal failure, there's pendulums. Intestinal transplants, everybody needs an intestinal transplant. Nobody needs an intestinal transplant. Everybody needs a step. Nobody needs a step, right? Like we all have to kind of meet halfway, right, in the middle. And I think the step procedure is a good surgery for the right patient at the right time by the right surgeon, right? And so who do we pick for that step procedure? Usually patients that have adapted on their own for a period of time. For some reason, 50%, 60% on their own is usually where you can get them. And as we talked about earlier, what do you do when you get stuck? So to mention, what we're talking about, how do I know that this patient, needs a step? We usually don't do routine, studies to see if the bowel is dilated. All short guts will have a dilated bowel, some more than others, right? But if, again, you have a patient that has had, your advancing feeds, and they're all of a sudden not tolerating more than they used to, right? You used to advance them every week on Mondays and Thursdays, and now you haven't been able to for a couple of weeks. You're stuck. That patient, we may get an upper GI and see if the bowel's dilated. A patient that comes in with a lot of infections that you think are coming from the gut, they have, bacterial overgrowth, that patient will get a study. And usually, I feel that it's better if you step a longer piece of bowel. So if, say they have 25 centimeters and only 10 centimeters are dilated, my surgeons are more likely to say, hold on. Wait, keep rehabbing, even if you're going slower, because the more you push, the more it's going to dilate, and then we're going to get more bang for your buck. You're going to be able to rehabilitate or, step the entire bowel, not just 10 centimeters. Where if you remember back in the day, if a surgeon opened the first time a child with an atresia that has a dilated, proximal loop, they'll be like, oh, we're going to step at a primary step before you even start feeds. That to us is something we don't do anymore. So it's usually when you get stuck, if the entire bowel is dilated, and usually they look for 4 centimeters, if it's dilated more than 4 centimeters. And as we talked about before, if a patient is extremely dilated and having symptoms of bacterial overgrowth, we're more likely to do steps than we are to duclotide. And so that's why I love our team. Our team, our surgeon will come to our clinic, the intestinal rehab clinic, and be seen with the dietitian, with me, with the social worker, and we make the decision together. I actually make fun of one of the surgeons. He was the only one that bothered me during maternity leave. He would call me from the OR. I would not pick up the phone, and he would text me, it's me, pick up, it's me. And it was always because he had one of my patients in the operating room, and we had a plan, and he saw something different, and he wanted to make sure that we agreed, because you're talking about somebody's life. And any decision can push them to transplant, which we're trying to avoid. So the communication between the medical team, the surgical team, and everybody else, I think is the key in deciding let's go forth. And with that, I think we're very successful on the steps. But we don't do that many. But the ones we do, they do really well.
So 4 centimeters diameter of the lumen of the small intestine dilation, you want it, and then the longer the segment that you're going to step, the better.
Yeah, and I didn't answer your Bianchi versus
No,
versus
but I
step,
think it's going to be more
most
complicated.
Most people do, because that's what they were taught and that's what they feel comfortable with. Of course, the Bianchi gives you more bang for your buck, but unfortunately, not many centers have the expertise. There's only a few centers in the US.
It's a complex surgery.
Right.
And now I wanted to touch also the issue of intestinal transplantation. So when your patient comes for evaluation for intestinal transplant, and when you are picking the right patient for intestinal transplantation, I'm going to quote your surgeons, and this is something that I learned from your surgeons a long time ago, and Tekin and Rodrigo. They say to us, or to me once a while ago, you are sending the patients too late to us. So when the patients, they come to have this massive type of surgery, they are too sick. And then the chances of survival that you're giving to these kids is not that much. Mm-hmm. We are going to do the same. We are going to have a kid that looks like a rose. We are going to operate. We are going to create a mess. And then I'm going to give you a very sick kid for you to save. Right. So, the point is, still the earlier, the better for outcomes and success on these patients. What is the today criteria for evaluations? And
Yeah, pendulum, right? So 2005, big year. I think 2005 to 2010 was a big year. We learned about set procedures. We learned about Omegaven. 2012 adults get teduglutide. So the more and more advances that we've had in the world of intestinal failure that are medical and non-transplant surgical, the more transplant has been pushed to the side. And I think what we're facing now is that the people that are taking care of intestinal failure patients this day and age, that remember taking care of intestinal transplant patients because it was much more common back then, remember the days when it was 50% survival. When you lose half of your patients when you're training, let's say, you don't think something is good, right? And so most people that do intestinal failure now remember that bad outcome. And now, as I mentioned, we're able to take care of these kids for years on TPN without having any complications. Why would you refer for transplant? I'm not going to send my patient to die, right? What they haven't seen is that just like we've made a lot of improvements in intestinal rehab, we have as well, because of the intestinal rehab movement, we've been able to take the time to see what did we do wrong in the past and how can we make it better, and we've made it better. So now the outcomes are not 50% survival. They're 90% survival, 5-year survival in certain centers that do intestinal transplant a lot, right? So that, you ask about the indications. Right now, we're kind of still living with the 2001 indications, which were the original indications for transplant when there was no home TPN, right? Or at least no home TPN in many centers like there is now, right? So back then, we used to say TPN, or parenteral nutrition-associated liver disease, which we're not really seeing, right? That we're not getting the yellow babies anymore. Central line infections, right? Recurrent infections, bad infections with fungus. Most of us use different therapies to prevent infection nowadays, so you don't see it as much. And then access, right? So back in the day, you had an infection, you take the line out, you have 6 main lines that you can use TPN in their body. You take a line out, you risk that it's gonna clot. Now you're left with 5. And then you take another line out, then you're left with 4. What has happened now is, because of all the medical treatment that we've done, is that we've kind of eliminated those. Not that they don't happen, but we kind of have eliminated them. Or what I think truly happens is that people have a false sense of security, and they're not really looking as much for the problem. So for example, it's not obvious anymore that you have a yellow baby, right? That doesn't mean the patient's not cirrhotic. Are you getting ultrasounds to see if there's any signs of portal hypertension? Are you getting a fibroscan to see if there's fibrosis? Are you getting a liver biopsy? Probably the answer is no, 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 right? Because there's no liver disease nowadays, right? Line infections, for the most part, you're doing, ethanol locks and all this stuff to prevent them. But if you have them, the understanding is that I'm not referring the child unless they've been in the ICU and they're on a ventilator or they're on a presser. Well, in my day and age now, if one of my patients is in the ICU on a presser or a ventilator, that parent probably kept the kid at home for 2-3 days before they took them out to the hospital. They're septic. Probably not a good transplant patient, right? So you're holding on to that side. And then lastly, the clots. People are using ultrasound. So there's a really good study that actually one of our fellows did. She's an attending now, Dr. Hochberg, that showed that if you only followed ultrasound, you can miss half of the clots that a patient has. Why? Because you're just sitting there with an ultrasonographer that does this. You're not really following the vein all throughout, all the way into the heart, right? So you can think a vein is open because you see a big collateral, like a big, bypass vein that has opened in your body, and you say, oh, it's open. But when the patient goes to IR or surgery, they can't put the line in. That patient probably has a partial clot. So we tend to use now MRVs more often in the patients that need a lot of lines. So what the new criteria are going to show, which again is this consortium that I mentioned of 20 experts from around the world, including adult, pediatric, GI, and surgery, is that we need to meet in the middle, right? So access is important. You want me to transplant a patient that has no access? What happens in 3 years? That patient, say it's a 15-year-old, they go to college, they end up with some bad viral infection in the dorm, and now I have to give them some antiviral, and I can't get a peripheral IV, and I need to get a line. If I have no access, the patient dies from something that's very treatable, right? Infections. If you hang on to the child until they have multi-drug resistant organisms, right, because they've used all these antibiotics, those patients we know now that are 7 times more likely to die post-transplant, right? Combination of the two. If you send a patient to me when there's only one access point and they have multi-drug resistant organisms, I have to keep that line in for a longer period of time, or a port, in a patient that's colonized with bad bacteria, and now I'm giving them immunosuppression. That patient's probably gonna die of an infection, right? So we're asking the intestinal rehab community to meet us halfway. Not to send everybody to transplant, but to make sure that we're working together to refer, maybe not even for transplant, but as a consultation, right? And for the transplant people to be able to educate the community that outcomes are actually really good. And I credit the intestinal rehab movement for that. Why? If I have a baby that has no gut, born, they lose all their gut, their duodenum to colon. During the first year, 2 years, 3 years of life, I watch that family. And I see, are they showing up for appointments? Are they going for labs? When the patient has a fever, are they going, into the hospital? If the answers are yes, 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 if they've taken excellent care of their kid before transplant, they're gonna take excellent care of their kid after transplant. And you're selecting the cream of the crop, right? We're transplanting good patients, good families, right? That's how you get 90% survival, in addition to some of the other changes we've made.
At what age you start taking these patients or accepting these patients for evaluation? I mean, back in the day, where even babies were done.
Correct. So we always have that rule that everybody says 10 kilos, 1 year of age. As you've mentioned, can we evaluate a baby sooner? Absolutely. We've done, you remember, 3-4 kilo babies back in the day, right? The problem is when you're transplanting somebody younger, you're waiting for a donor that's smaller. That's one of the differences now. We don't, back in the day, if we needed to get an organ right away, we may take something bigger and either the baby stays with an open abdomen or you may cut the liver, you may cut the intestine. Like, you're cutting things to make it fit. Now we really wait until, because we can, to get a perfect graft, right? But can we do an 8 kilo, 8-month baby? Absolutely, we can. The same thing happens. A lot of my babies that they know they're going to get a transplant at 1 year of age, they say, I want to be evaluated. Okay, we'll evaluate you. But you're waiting to get a good organ. So they may wait till they're 1.5, 2 even, 3 to get an organ as you wait for the perfect organ. There's no rush to just transplant them because they're not dying, right? And so if you ask me personally, I think 2.5, 3 years old is the perfect age. Why? Because they've gotten vaccinated. They're big enough, right, where they're you're able to get more offers. You've tested out the family more. The surgery's easier. Now we can talk about this forever. We now do transplants without a stoma, so we're able to close their stoma right away. One surgery, you're done. So I think that the intestinal rehab movement has helped us improve outcomes in intestinal transplant.
So what is your index? And I'm just going to touch this briefly. What is your index of suspicions or rejection if you don't have an ostomy to check for that rejection anymore?
Yeah, so
you just do a regular EGD?
You do a regular colonoscopy. Usually as early as 10 days post-transplant, we feel comfortable doing them. I mean, not every GI does, but I feel comfortable scoping, and the people that do the most. So yeah, diarrhea, usually same fever, that kind of thing. Rejection's not as common as we used to see. I think in retrospect, we used to overdiagnose rejection because, you're basing rejection off these abnormal cells that you see, apoptosis, and you say, oh, they have more than however many cells, therefore they're rejecting. I feel
and then more immunosuppression, so you're overdiagnosed rejection, then you're immunosuppress more your patients, and then more chances of mortality. That's
correct. So, and we used to, anything abnormal, it's rejection, give them steroids. It's rejection, give them steroids. So we absolutely lost a lot of patients from infection, which we don't do now. When we stopped doing ostomies, initially in multiviscerals in 2013, we actually started seeing less rejection. And you can argue that, multiviscerals, they reject less than intestinal isolated. So that's why, because of the liver protection. But I think it's because we were looking less, and then you have a team that's also very experienced and knows what to look for. But, the theory came from Crohn's and microbiome, right? So you have a bowel. If you remember, whenever we were scoping me as a fellow using attending, you would always tell me you have to go further. If you did a biopsy within the first 10 centimeters, usually they would call that abnormal. So I remember one October day in 2013, Rodrigo calls me down to the OR and he's like, how's this kid colon? And I'm freaking out. I think something happened to the kid's colon. And he was like, I think I'm going to close the stoma. And there, talking to him, we came to that conclusion that, is it the microbiome? Like, you have this brand new bowel that's hanging out next to stool that doesn't belong to the person. It's new stool from the donor, right? And is this new body seeing a new microbiome, and that interaction is what triggers the rejection to start in that last piece, right? So when you take that away and now the body's closed, right, you're not exposed to the outside, it's further from the rectum, the part that rejects first, you're just not seeing it as
much. It
much.
makes a lot of sense to too many ostomies. I mean, even your protocols have changed. Your surgical protocols of not having an ostomy, which I think is a great idea, has changed too.
But we were able to do it because we were at the right place at the right time with a team that, I have 3 senior surgeons, not just Dr. Viana, but Dr. Tech and Dr. Gennaro Salvaggi, who've been doing this for 25 years, right? And you have
Gennaro has been doing
gastroenterologist has been there for, 15 years and attending, trained, in bowel for 6 years before that. The ICU, most of our attendings, at least half of them are older and were there back in the day when we used to see 20, 30 a year, right? So infectious disease, everything you breathe, sleep, see is transplant. You become much more comfortable.
How many small intestines are you transplanting now?
We're doing around pediatric. We're doing around 8. I think, 2 years ago we did 10, which was a big year. I think around 8 is our good.
Still a good number.
A good number.
So you say that your your outcome survival is 5 years, 92%, which is
Yeah.
very good.
And I credit, again, the IBD world for that. And,
Yeah, so it's an excellent one.
we've changed our immunosuppression protocol. One of the things that changed dramatically since you've been with us is back before it was about saving the graft, save the graft, save the graft, save the graft. I remember Dr. Viana started in 2013, and I, didn't think retransplant was a possibility, because when I was in training, if we retransplants always died. And the reason they died, we realized, it's not because of the retransplant, it's because we gave the patient so much immunosuppression trying to save the graft that by the time you give them a new graft and immunosuppress them more, they die from an infection. So now we will try once to save the graft. If it doesn't work, we rather retransplant the patient. And with that, we've had really, really good outcomes. And then the other thing we've done is that now we include some of the newer IBD medications. So for example, vedolizumab, it's a wonderful medicine for us. It's for Crohn's, as you know. It prevents the attachment of T cells, activated T cells, to the bowel in Crohn's. What produces rejection? T cells. So if we have a patient, that we think has rejection, for example, we don't give them the big guns that we used to anymore. We'll give them something that just treats the bowel, right? So you're immunosuppressing them in the bowel and not the rest of their
And
body.
that's in combination with tacrolimus and the initial bout of corticosteroids.
Yeah, so for induction, we've, in the last actually 2 years, because we have been seeing less and less rejection, we actually introduced vedolizumab to our induction, meaning when you get your transplant, we're using vedolizumab in the beginning. They still get thymoglobulin, but in the past we were doing 5 doses of thymoglobulin, a lot of immunosuppression. Now we're only doing 3, because we're giving them, after the 3 of thymo, we're giving them 3 of vedolizumab. And actually, we have plans to probably use vedolizumab even more and use even less and less tacrolimus, because again,
And it doesn't have much there. I mean, the IBD work has shown that's one of the safety drugs, biologics
Correct.
that we can use.
Correct. So we've
Vedo.
experimenting it more. We started with rejection, then we went to induction, and now we're actually thinking about using it for maintenance. And I have some adults that have been transplanted for Crohn's, and we've kept them on vedolizumab after transplant, fearing that their Crohn's will come back. And we've noticed that those patients, we tend to need less and less Prograf, obviously, because they're an immunosuppressive agent. So I think, just like in the intestinal failure world, that newer and newer medications are coming, same thing is going to happen in the transplant side.
I'm going to ask you the last question. So in terms of outcomes, or what your center is doing, you are doing more and the type of intestinal transplantation. Are you doing more isolated small bowel transplant, or combined liver and small transplant, or multi-result? What the center is doing now more?
Yeah,
nowadays?
so we don't do any combined liver intestines. I don't think many centers do anymore. We used to do, and probably still do, more multiviscerals than we do isolated. That is for a reason. One of the more obvious reasons is the indication for the transplant. I think we're in a stage right now where the shortcuts are being held on to by the GI team, right? Because they're doing well on TPN, right? And because a lot of parents are scared of transplant. So that's why I think it's so important in the new indications, there's going to be different indication for consult, just for education, just to tell the parents, this is an option maybe in your life. You may not need it. Let's hope you don't need it, but don't be scared. If you need it, we'll get through it. And then there's, the patients that need to go for transplant, but that's another story. So going back to the indication, because the GIs are holding on to the short bowels, a lot of the patients that are being referred for transplant are dysmotility patients, or patients, as you mentioned, MMI, microvillus inclusion, aganglionosis, patients that have no rehab potential, and their disease affects the stomach. So if your disease affects the stomach and you need a stomach transplant to fix the entire disease, to get, let them have new organs from scratch, if they're less than 30, 40 kilos, they need what we call a multivisceral, which means you give them a liver for free. And I say in quotations, for free, because as we were talking about, although you think these patients' livers are fine, the reality is when the livers come out, we notice that even though their numbers are normal, biochemistries are normal, they have significant fibrosis. And most of them have stage 3 out of 4 fibrosis, right? So we always wonder if the bad name that isolated intestines get, right? Because everybody says, isolated intestine is like a kidney. If you get one now, you're going to need another one in 10 years because you're going to go into chronic rejection. We always wonder, what is the liver component having to do? Like if you're transplanting the patient with a relatively bad liver, what is the outflow of, the graft, the blood flow out to the heart? Like, what is that going to do? Is that going to affect the isolated? Does it have any effect? So as a center, we prefer multiviscerals, but we don't just give a liver if you don't need it, right? Like, you have to have an indication. But again, I think more and more isolated now, but still more of a multivisceral center.
Well, like I say, I mean, I'm super glad that you were here today. It was a super nice talk.
No,
Hopefully the audience is going to enjoy. It's a lot of new things, and I'm super glad. I'm proud of the very good job that you're doing there, and keeping that very high standards of the center. And what I'm learning from you is just that. I mean, organizing the team, having a good team to support your populations and patients, and that would be surgeons, gastroenterologists, nurse practitioners, social workers, dietitian,
Yeah.
everyone in the team, and that what it makes a key of a good medical practice.
Absolutely.
And,
The goal of MTI is always one team, one goal.
congratulations, and hopefully we see you soon leading something bigger.
Maybe.
A bigger enterprise.
Maybe. You never know. I believe in intestinal transplant. I love intestinal rehab. I'm very proud of the fact that we hardly ever transplant our own patients. I think if you have a good team getting you through the journey of adaptation, I think, we're successful in it. But I really hope that in my lifetime, we get back to realizing that there is a role for transplant, that it could be done safely, and that it's going to continue to be alive, right? There's many of us that fear that intestinal transplant is going to lose its role because there's so much less and less of them being done, but I don't think so. I think that it's here to stay. Hopefully we'll be able to now push again the nation to continue doing them and teaching the future.
Congratulations again.
Thank you so much. Thanks for having me. Thanks.